This data was presented at EHA, and this was looking at the AML18 trial, which is a trial for patients over the age of 60 who are fit for intensive therapy, primarily patients with favorable or intermediate risk cytogenetics, was updated at EHA. There were a number of aspects of the trial, but the data that we presented was on the initial upfront randomization, where we were analyzing the impact of dose of Gemtuzumab. The question here was, in the UK, in our AML16 and 17 trials, we've just used a single dose of Gemtuzumab, 3 milligram per meter squared, combined with DA chemotherapy. Of course, the approved schedule by the EMA and by NICE is for the full alpha schedule, which actually uses 5 doses of Gemtuzumab, 3 in course 1 and 1 in course 2 and 1 in course 3. But this has been not something that there's a lot of experience in the UK. So even prior to the EMA approval, we'd started this study comparing a fractionated schedule of Gemtuzumab as used in the alpha study 0701 trial, randomizing against a single dose of Gemtuzumab as used in our previous AML16 trial. And we've randomized over 840 patients into this question. And the bottom line is that the response rate, overall response rates, was identical between the two arms, and there was no difference, no significant difference that has emerged in overall survival. Neither was there a reduction in the cumulative incidence of relapse or an improvement in relapse-free survival. So the data does not suggest a benefit for using a fractionated schedule. Now, we didn't use the approved schedule of fractionated schedule of Gemtuzumab. We used just 2 doses on days 1 and 4 of chemotherapy, randomized against just 1 dose on day 1. And we didn't use the 3-dose schedule as used in the Alpha 0701 trial because they had significant issues with delayed platelet count recovery in that trial, and about a 4.5% incidence of veno-occlusive disease of the liver. So we opted to use a slightly lower dose fractionated schedule. But overall, as I say, we showed no benefit for the higher, the fractionated schedule. We do plan to do a meta-analysis with PET data from the AML19 trial, where we also randomized a similar Gemtuzumab question in younger patients with AML, and that will enable us to analyze well over 1,500 patients in this question. One of the interesting things that emerged from the AML18 analysis was, in our previous trial, the outcome for patients, we measured minimal residual disease on patients following course 1 of induction. And in AML16, patients who are MRD positive had a much higher cumulative incidence of relapse and a poorer overall survival than patients who are MRD negative. In AML18, we asked the question, does treatment intensification of these MRD positive patients post-course 1 improve their outcome? And although we haven't analyzed that data formally as yet, because the trial is ongoing in this particular question, the early analysis suggests that the outcome for patients who are MRD positive is now similar to that of outcome for patients who are MRD negative. And we're not sure of the reason for that. Is it the application or more intensive therapy at course 2 for these patients, or is it the impact of increased numbers of allografts benefiting patients who are previously MRD positive, who are MRD positive? So this is a very interesting observation, one that we're going to have to follow up more closely.